Welcome to everybody in Moscow. I cannot share my slides, so I would need the slides being shared from your side. Okay, thank you. Now I see the slides. 25 years ago, we saw a transition from GDX to OCT, whereas from HRT and GDX to OCT. And the reason is that OCT really revolutionized structural imaging in glaucoma, because it provides unprecedented resolution and gives more information than either HRT or GDX. Next slide. So what is actually, this is actually not the next slide. I think you missed one. Can you go back? And one more back. I think you missed one slide. Yeah, let's continue with this now. So this is something that I'm sure you have seen a lot of times. This was the so-called glaucoma continuum that was actually introduced by Bob Weinreb some 15 years ago. And it indicates that we have three stages of the disease: the undetectable disease, the asymptomatic disease, and the functional impairment. And particularly in this asymptomatic disease stage, one would expect that you have structural changes that you can maybe detect with OCT, but you have not yet any changes that you can detect with current perimetry. And only later we move to a functional impairment, where then the functional changes as measured in OCT, as measured in perimetry, will occur. Now go further. Next. Next. Okay, so generally, what do we expect from a diagnostic tool? When is a diagnostic tool useful? It needs to provide high sensitivity and specificity. It should provide objective reading with minimal user dependence. It should allow to obtain information that is unavailable via any other available instruments. It should be applicable to many diseases. It should provide short measurement time, and it should be easy to operate. And as you see, pretty much all of these factors are fulfilled go back. So pretty much of this is fulfilled by OCT. And that's the reason why OCT at the end of the day has become so successful in characterizing the structural defects in glaucoma. Next slide. Now the really important question is, how good is the diagnostic performance of OCT in detecting glaucoma? And this is an interesting study from the lab in San Diego that followed 142 eyes of glaucoma suspects longitudinally, and the longitudinal progression was confirmed. And actually it was figured out that over 9 years approximately, 95 and here you can see that the OCT is pretty good in actually detecting which of these glaucoma suspects were going to develop glaucoma in the future. And this really indicates, and by the way, this was true for both macular and optic nerve scans, and this really indicates that OCT is relatively good in detecting glaucoma, and particularly also in longitudinal studies to detect those that will develop glaucoma. Next slide. Now, obviously, the diagnostic performance of OCT for detecting glaucoma depends very much on the stage. And you can see here that the more advanced the glaucoma, the better is the diagnostic performance. But of course, in this late stage disease, OCT is generally not so helpful. So in early stage of disease, you can see that we obtain an area under the curve, which is approximately 0.8 to 0.85. Next slide. But what are the problems with current glaucoma devices. On the one hand, when we talk about retinal nerve fiber layer thickness, we have relatively poor contrast. As such, it is difficult to segment, and we sometimes have segmentation errors. We have poor agreement between different instruments, and this is mainly because different vendors use different softwares. We have many components that are not nerve fibers when we measure the nerve fiber layer thickness. For instance, the glial cells and the blood vessels. And RNFL does not go to zero when all fibers are gone, and this is the so-called residual effect. Many of these limitations or problems also apply to ganglion cell complex. It is again that many components may be in this layer that are not ganglion cells, for instance, dislocated amacrine cells. Next slide. So as I've said before, there is a problem that in all OCT machines, we have a dynamic and a residual range. And that's also the reason, coming back to the question, what is more important, why in early stage disease, the OCT may be superior in detecting progression to the visual field. But in late stage disease, you see that we have a residual range, and up from an ND of approximately -10, the use of the OCT becomes less and less important because of this residual range. What you can also see in this study is that the residual range is not equal with all the instruments. Now, all the major vendors now have glaucoma progression analysis on structural data, pretty similar to what is offered by the visual fields. But you must, of course, be careful because this is only structural changes that you evaluate here, and you cannot really distinguish from age-related changes. So what are the pros and cons of OCT over visual field? It is fast and easy, particularly it's important in the earlier stages. It is an objective documentation, and it has better reproducibility. And this means that often you need less measurements to detect progression. On the other hand, the change in structure is of course not relevant for the patient's quality of life, and it is difficult to distinguish between age-related loss and glaucomatous loss. Next. So in practical terms, I think the guidelines, the EGS guidelines, give good advice. So glaucoma is particularly important. Glaucoma imaging is particularly important in early and moderate damage. And the frequency should be similar to that of visual field testing. And at the end of the day, if you want to have a clear diagnosis and look into progression of the disease, nowadays we think that it's state of the art to do both the OCT and the visual field at the same time. And I think all glaucoma specialists would more or less nowadays agree that this is state of the art. Next slide. Now, Natalia has also asked me to talk a little bit about OCT angiography. I think OCT angiography is still an experimental tool. We don't use it for clinical routine, but research-wise, it's still interesting. The reason why we don't use it for patients routinely is, on the one hand, that it's difficult to get good scans. And on the other hand, as you can see here, the diagnostic performance of the vasculature seems to be weaker than that of the structural OCT measures. Next. It may be different, however, with wide field OCT systems. This is a prototype, for instance, from Zeiss that provides a 12 by 12 or a montage 20 by 20 millimeters. And then you can also much better correlate this to the visual field. Next. And we have recently developed a method how to correlate the vessel density. This is shown here on the right. with the visual field and a comparison with nerve fiber layer thickness compared to the visual field on the left. And the red dots indicate non-significant correlations, and the green dots indicate significant correlations. And you can very clearly see that, interestingly, the correlation between visual field and structural changes is much better when you rely on the vasculature as compared to the thickness of these tissues. And this is something that is interesting and also gives some hope. Next slide. And at the same time, we have observed in the study, the upper graphs are the correlations with nerve fiber layer thickness, and the lower ones are those with vascular density. And you can see here that at late stage disease, particularly the correlation is much better, and the vasculature shows much less of a residual effect than the thickness. So maybe, and this is something that we are looking at the moment, these vascular measurements may be particularly interesting to detect progression in late stage disease. But this is something that still needs more clarification. On the other hand, I don't think that OCT at the moment is a standard tool that you need for glaucoma diagnosis or progression analysis. And with this, next slide. With this, I would like to thank you for your attention.